Assalamualaikum and good afternoon. I'm presenting the topic of geriatric trauma. Please be with me for the next 30 minutes. This lecture outline for this topic. Worldwide, the aging population is progressing. So currently, 14% of world population is more than 65 years old. And by 2050, more than 20% of world population is older than 65 years old. In Malaysia, our population life expectancy is 73 years, with male 70.3 years old and female 75.9 years old. 5% of our population is more than 65 years old. US data shows 25% of injury fatalities per year is due to elderly trauma and consume about 33% healthcare resources spent on trauma care. The objective of this lecture are to identify the unique characteristic of elderly trauma patient in the aspect of type of injury, patterns of injury, anatomic and physiologic differences compared to young adults. To understand primary management of critical injuries in geriatric patients and to identify elements that leads to suspicions of abuse of the elderly. By definition, geriatric meaning elderly age more than 65 years old. It's subdivided into young old, who is between 65 to 80 years old, and old, who is over 80 years old. So what is clinical importance for these categories? So it is important because patients are more than 80 years old have a significantly poorer outcome when get injured. Now we look at the physiology of aging involving the multi-systems in geriatric. In elderly, bone become osteoporosis, causing patient less able to withstand mechanical forces of trauma. Even with less kinetic energy can cause fracture, such as with ground level falls. Patient can sustain traumatic brain injury, pelvic fracture, or even long bone fracture. Diminished functional reserve in heart, therefore have a lower cardiac output, decreased cardiac reserve, and unable to tolerate hemodynamic stress. Aging of the electrical conducting system or pharmacoactivity of beta blockers or calcium channel blocker in hypertensive patient with this medication causing decreased heart rate response to the catecholamines, therefore has blunted inotropic and chronotropic response to trauma and absence of compensatory tachycardia. Presence of heart failure in elderly causing diminished cardiac output. If patient has a heart block, it will cause blunt rate response to stress. In coronary artery disease, they may manifest as demand ischemia during the stress of trauma. Therefore, the risk of an acute cardiac event must be considered in every case of trauma in the elderly, and ECG is mandatory in trauma elderly patients. In geriatric patients, maximum tachycardia response decreases, and you can calculate the maximal heart rate with 220 minus the patient age. So let's say patient age is 70 years old, the maximal heart rate is 220 minus 70, which is 150 beats per minute. In geriatric patients, presence of atherosclerosis in blood vessels due to intrinsic aging change on the arterial wall causing the systolic hypertension. Besides that, atherosclerosis also causing increased impedance of the central elastic vessels leads to decrease the ejection fractions and also decelerates the aortic flow. Aging in respiratory system causing chest wall and lungs rigidity, therefore decrease mechanical compliance and an increase in work of breathing. An alveolar loss due to aging and decreased diffusion capacity causing decline in arterial oxygen tensions. The vital capacity, forced expiratory volume, and functional residual capacity also compromise with age. All of this you need to consider in managing of ventilations in geriatric patients. Risk of hypoxemia and hypercarbia also high compared to young adults. And due to diminished control of breathing, causing decreased response to hypoxia and also hypercapnia. In elderly, brain also become atrophy, causing stretching of the bridging vessels of the brain, results in increased susceptibility to tearing under shear forces. If tearing these bridging vessels, these patients will present with a subdural hemorrhage. Dura also tied to the skull and more CSF due to shrink of the brain. With aging, the cerebrovascular autoregulations also decline, and it's explained the worst outcome seen in the elderly patient with trauma. So the loss of water and proteins also affect shape of the trabecular drainage. Aging in kidney resulting in loss of nephrons at 0.5 to 1% a year. Also decline of GFR and creatinine clearance, therefore susceptible to hypovolemia. For skin, reduced defense against microorganisms, loss of temperature regulations, therefore prone to hypothermia and also has delayed wound healing. During the assessment of patients, must ask the patient's comorbid. The comorbid or pre-existing conditions impact morbidity and mortality in patients. Presence of liver disease has high mortality from the risk of bleeding and uncontrolled hemorrhage. Patient with end-stage failure has a high mortality after a trauma, whereas diabetic patients may present with a hyper or hypoglycemia. So the history of pre-existing medication is also important. Beta blocker or antihypertensive may decrease the patient's compensatory hemodynamic response to the hemorrhage or volume loss. Patient with oral warfarin, aspirin, and other antiplatelet has higher mortality if has intracranial bleeding. Psychotropic medications such as antidepressant, neuroleptic, and sedative may make the assessment of mental status difficult and unreliable. So hypotension should never be attributed to blood pressure medications until hemorrhage and ischemia have been ruled out. Because in trauma, the most common causes of hypotension is due to hemorrhage or bleeding, and heart ischemia also may lead to the trauma happen. Patient with a history of hypertension and a normal BP is unstable until proven otherwise. Because hypotensive patient usually has a high BP than normal. If has a normal BP, patient may has relative hypotensive state. Common biomechanism of trauma encountered in elderly patients include falls, 60.7%, motor vehicle accidents, 21.5%, pedestrians injured by automobiles, and burns. So falls are the most common mechanism of fatal injury in elderly populations, commonly due to the low-level falls. The injuries tend to be more severe than the injuries sustained by younger patients from similar falls. Head, pelvis, and lower extremities injuries are extremely common in elderly falls. The physician must not only diagnose the injury, but also to investigate the cause of the fall. So major risk factors for falls include older age, female gender, history of a previous fall, lower extremity weakness, balance difficulties, psychotropic drug use, and also arthritis. About 50% of fall associated with traumatic brain injury, and 50% patient with hip fracture never be able to live independently. The environmental factors that are associated with falls, such as loose rocks, poor lighting, slippery, or even uneven surfaces. Motor vehicle accidents are the second most common injury mechanism in the age group greater than 65 years. The high-risk elderly groups for motor vehicle accidents includes the presence of acute and chronic medical conditions that affects a patient's vision, such as patients with a larger blind spot, slower reflexes or reaction time, decrease in ambulatory speeds, imbalance or unsteady gait, have cognitive impairment, decreased hearing, and limited cervical mobility. Orthopedestrian accidents follows the MVA as the third most common mechanism of injury in geriatric patients. High-risk group with pedestrians struck by vehicles includes elderly with slow ambulations, has impaired reflexes, misjudgment with the distance, has visual, auditory, and gait impairment, decreased peripheral visions, and progressive kyphosis make elderly more difficult to see the road ahead, thus the oncoming traffic. Progressive deafness means warning horns are less likely to be heard by the pedestrian. They have higher morbidity and fatality with injuries to the brain, spine, and also thorax. Skeletal injuries increase dramatically with age due to the older adult is more prone to fractures after minor falls and lower energy impacts. Although injury to the abdomen do not. Burns in elderly resulting from the smoking in bed, alcohol influences, get caught in the building fire. The comorbid illness also complicates the outcome. Geriatric patients at risk in burns because of the slow ambulations and reaction times due to visual and auditory impairment and the inability to escape the burning structure. In case of spilled hot liquids on leg, in younger patients may reepithelize due to inadequate number of hair follicles, but in elderly patients will result in a full thickness burn with a paucity of follicles. And if you compare young adults patients and elderly patients, elderly trauma patients clearly have different patterns of injuries. So for central nervous system, intracranial bleed can result in elderly patients who sustain only minor head injury. Even with no evidence of significant skull fracture, no neurological deficits, or altered level of consciousness, and who are neurologically intact on arrival. Further increased risk if the patient is taking warfarin and other anticoagulants or antiplatelet agents. So for these reasons, more liberal use of CT scanning is warranted in this population. Elderly patients have 2 times more likely to get cervical spine fracture compared to young adults. With diminished senses, they are more prone to simple falls, which are the most common mechanism of spinal injury in elderly. Elderly falls from low height are at significantly increased risk of injury between the C1 and C2. Elderly patients in motor vehicle collisions and high falls are more likely to injure lower cervical vertebra. Geriatric patients has high incidence of injuries to the atlantoaxial, which is a C1, C2 complex. Therefore, all elderly patients requiring CT brain should do a CT cervical spine. Age-related changes in physiology make thoracic injuries particularly lethal in the elderly. In geriatric patients, mortality rises significantly with the number of rib fracture, from 12% in patients sustaining 1 to 2 rib fracture to nearly 40% in patients with 7 or more fracture. Minor chest injuries that would otherwise be inconsequential can lead to a significant complications. So pulmonary complications following the rib fracture in elderly include respiratory failure, pneumonia, and also a pleural effusion. The pitfalls in managing elderly trauma patients. Elderly patients can develop respiratory failure following fall with rib fractures. So how to prevent respiratory failure? Recognize the potential for pulmonary alterations in elderly patients with a rib fracture. Patients with rib fracture may also have a lung contusion, so further compromise the respiratory system. So provide effective and adequate analgesia to prevent the hypoventilation, which in turn can promote atelectasis, mucus plugging, and ultimately pneumonia. Provide adequate pulmonary toilet and recognize the patient's comorbid conditions and their impact on the response to the injury and medications. Elderly patients can develop deliriums after receiving long-acting narcotic dose. So how to prevent this medication's effect? So obtain medication history and note the potential interactions. Use smaller doses of short-acting narcotics when needed. Consider non-narcotic alternatives. Use transdermal local anesthetic block or epidural when possible. Rate of abdominal trauma in elderly similar to that of younger persons, but mortality rates are 4 times that of younger adults. So abdominal examination is traditionally considered less reliable in elderly patients because elderly often shows fewer peritoneal signs and tend to localize pain poorly. So due to this reason, liberal use of abdominal CT after trauma should be considered in all geriatric trauma patients. In elderly with a persistence of hip pain despite negative radiograph, need to consider significant incidence of occult fracture. Fracture of acetabulum can be easily missed on the radiograph. Fracture of the pelvis carry high morbidity, most common due to the pubic rhomboid fracture, about 56%, followed by acetabular fracture, 19%, and ischium fracture, 11%. Mortality from pelvic fracture is 4 times higher in older patients than in younger patients. In major trauma patients, pelvic fracture in the elderly patients are more likely to hemorrhage and die. So this is an X-ray for a patient with a history of falls and unable to ambulate after the falls due to the hip pain. This X-ray shows fracture of femoral neck. This fracture is easily to be missed and sometimes need to do MRI to confirm the fracture. So management of the geriatric trauma victims. So at the pre-hospital, do a rapid primary survey, airway, breathing, circulation, disability, and exposure, followed by scope and run transport. Bear in mind, because of the physiological aging, Compared to young adults, geriatric patients are intolerant of hypoxia and shock. Elicited history from the witness regarding the mechanism of injury. Very important to get an idea the severity of trauma and type of injury patients may sustain. Phone number of relatives or neighbors should be obtained if possible, because need to explore more regarding the patient's premorbid, comorbid, medication history, and etc. later in the hospital, especially if patient unable to communicate. So initial resuscitations in primary survey. In elderly trauma patients, the concerns in airway management includes dentitions. If patient has dentures, the dentures may loosen and obstruct the airway. But if the dentures are not obstructing the airway, leave them in place. It will help during the bed mask ventilation, as this improve the mask fit. They also has fragile nasopharyngeal, may has macroglossia, large tongue, macrostomia, small mouth. Placement of nasogastric tube may be difficult, and they may have arthritis at temporomandibular joint or cervical with the degenerative changes of spine, make mouth opening and cervical spine management is difficult. Also, they has a decrease in protective reflexes. So the principle of airway management is same as young adults. Establish and maintain airway patency, supplemental oxygen with a non-regulated heart to mask. Need to consider early intubations if airway is compromised. Some management considerations in managing airway in elderly patients. In irritants elderly, makes intubating easier but difficult during the bed mask ventilations. Need to use appropriate size laryngoscope and tubes. May need to place gauze between the gums and cheek to achieve seal when using a bed mask ventilations. Ensure appropriate dosing of rapid sequence intubations medication. In elderly, the dose of sedative agents need to reduce between 20 to 40% to minimize the risk of cardiovascular depressions. Breathing and ventilations. In managing breathing and ventilation, the pathological changes in elderly also need to be considered. Patients with pre-existing respiratory disease such as COPD, interpreting the clinical and laboratory information can be difficult. This type of patients may have chronic hypercarbia. Elderly with chest wall injuries may have rib fracture and also pulmonary contusion together. Need to give adequate pain control and pulmonary toilet to prevent complications of lung infection. Cautious with the fluid therapy. Too much fluid can lead to pulmonary edema and worsen the lung contusions. And pulmonary complications need to consider in elderly trauma includes atelectasis, pneumonia, and pulmonary edema. The physiological changes in elder that you need to concern include increased kyphoscoliosis, decreased functional residual capacity, therefore has limited respiratory reserve, decreased gas exchange due to the presence of atelectasis, decreased cough reflex, decreased mucociliary clearance from the airway. Age-related changes in the cardiovascular system place the elderly trauma patient at significant risk for being inaccurately categorized as hemodynamically normal. So normal BP, heart rate does not mean normal for elderly patient with multiple comorbid and multiple types of medication, such as patient with a cardiac disease and also hypertension. A significant volume loss masked by absence of early tachycardia due to the lack of classic response to the hypovolemia. Elderly patient has limited physiological reserve, therefore has inadequate response to injury and may lead to acidosis. Caution with fluid administrations in elderly, too much can cause pulmonary edema. They can present with retroperitoneal bleed even with a minor pelvic fracture also. Managing circulations in elderly patients include early and aggressive monitoring of cerebrovascular system, cardiovascular system. Monitor crystalloid infusions. You can give 1 liter of warm crystalloid. Ringer's lactate is a better choice in the elderly patient because it is balanced solutions. Lactate that is converted by the liver to bicarb tends to further buffer any existing lactate acidosis. But if you give too much normal saline, it will lead to hyperchloremic acidosis. If after volume restorations, still hypotension, so start inotropic support. In traumatic brain injury, maintain the MAP around 80 millimeter mercury. Maintain hemoglobin more than 10 gram. Low HB will cause cardiac ischemia. Look for the sites of bleeding, including the peritoneal space, retroperitoneal space, pelvic bone fracture, long bone fracture. A patient with a significant tissue hypoperfusion, ABG will show increased space deficit or an elevated serum lactate. So pitfall in failure to recognize shock. Do not equate BP with shock, because in elderly patients with hypertension, the acceptable BP may reflect hypotensive state. Recognize the likelihood of pre-existing hypertension and, when possible, obtain medical history. Use serum markers such as lactate and base deficit to evaluate for evidence of shock. Use non-invasive studies such as echocardiography to assess global function and volume status. And recognize the potential for increased blood loss from soft tissue injuries and pelvic and long bone fractures. In elderly, moderate cerebral atrophy may permit intracranial pathology to initially present with a normal neurological examination, then later present with an increase of intracranial pressure symptoms. So, in degenerative spine disease places elderly patients at risk for spine fracture and spinal cord injury with low kinetic ground level fractures, ground level fall. Therefore, liberally use CT imaging to identify brain and spine injuries is important in the elderly. In the presence of pre-existing neurological or psychiatric disease in elderly, it will result in difficulty to assess patient's neurological status during the examination. Elderly has a higher incidence of subdural hemorrhage or intracranial bleeding, but has gradual onset of symptoms due to the cerebral atrophy. Because of this reason, liberal use of CT brain in the elderly trauma is emphasized. Cervical spine injuries are common and difficult to diagnose due to the degenerative changes, and patients may have underlying osteoporosis, osteoarthritis, or canal stenosis. In certain cases, may need to consider MRI early if suspected of spinal cord injury. Ensure early reversal of anticoagulant and or antiplatelet therapy in traumatic brain injury patients those on anticoagulants and antiplatelet medication. It can improve outcomes in this elderly patient. Aging process in elderly causes the loss of subcutaneous fat, loss of skin elasticity, arthritic changes, skeletal changes, and nutritional deficiencies. All of these place elderly patients at risk of hypothermia and the complications of immobility such as the pressure injuries and also delirium. So to prevent hypothermia in elderly, ensure given warm fluids, warm blanket, monitor their temperature regularly. Hypothermia can lead to myocardial irritability and subsequent arrhythmia. The skin is easily injured, causing invasions of the bacteria. So in injured patients, ask regarding the tetanus immunizations and give ATT if needed. Special circumstances that require consideration in the treatment of elderly trauma patients include medications and elderly maltreatment. Medications need to consider drug interactions between patient's own medication and also medication you want to give. If want to give medications such as NSAIDs, steroids, ask about the allergy. Comorbid that may contraindicated for this medication. If patients on anticoagulant, antiplatelet, or use of direct thrombin inhibitors, it poses a significant problems for the bleeding patients. So rapidly identifying the type of drugs and then instituting a reversal agent if available may save the patient's life. Give adequate pain relief, regular ask about the pain score, and top up the analgesia if needed. When evaluating an injured elderly patient, you should consider the possibility of maltreatment also. So maltreatment is defined as any willful inflictions of injury, unreasonable confinement, intimidation, cruel punishment resulting physical harm, pain, and also mental anguish. So elder maltreatment can be divided into 6 categories: physical maltreatment, sexual maltreatment, neglect, psychological maltreatment, financial and material exploitations, and also violations of rights. Physical maltreatments occur in up to 14% of geriatric trauma admissions, resulting in a higher mortality than in younger patients. Physical findings suggestive of elder maltreatments includes contusions affecting the inner arms, inner thighs, palms, soles, scalp, ear, mastoid area, also buttocks. Multiple encrusted contusions, abrasions to the axillary area due to restraint or the wrist and ankles from ligatures, nasal bridge and temple injury from being struck while wearing eyeglasses, periorbital ecchymosis, oral injury, unusual alopecia pattern, untreated pressure injuries or ulcers in non-lumbosacral areas, untreated fractures, fractures not involving the hip, humerus, or vertebra, injuries in various stages of evolutions, injuries to the eyes or nose, contact burns and scalps, and also scalp hemorrhage or hematoma. With that, thank you for your attention.